My name is Dr. Angelique Barreto. I am a regenerative medicine specialist based in Oklahoma City, Oklahoma in the USA. I run a clinic in Oklahoma and we cater to several patients with joint pain in whom we practice specialized joint injections using autologous conditioned serum. My talk today is about osteoarthritis, the current thinking regarding the causes of arthritis. I then present a summary of the current modes of treatment available, and then there is some special emphasis on the regenerative options that are out there to treat osteoarthritis. So in the past, the thinking about was pretty much a mechanically mediated disease related to age, wear and tear. Patients who are obese are more likely to struggle with this disease, etc. Clinicians typically used imaging to categorize degrees of arthritis as mild, moderate, severe, bone on bone, etc. However, that thinking has changed considerably over the last few years, where we understand that it is possible to have symptoms without extensive features on imaging. The reason for that is because the triggers that set off arthritis actually trigger off a pro-inflammation cycle to start in the joint. The main conductor of this orchestra, as we know, is the cytokine called interleukin 1 or interleukin 1 beta. As soon as this cytokine is triggered by injury, repetitive stress, obesity, friction, etc., it sets off a pattern and a cascade of other chemicals to be produced in the joint, which then subsequently damage the joint, as you'll see in a few slides going forward. This is a little summary, again, just talking about what we thought in the past, wear and tear, repetitive stress, whereas the current thinking is more in line with inflammation being the primary cause of osteoarthritis and the symptoms of arthritis. Thereby, our treatment approaches have expanded and changed. So we have several non-pharmacological options when we come to treating patients with arthritis. We always must remember to talk to them about lifestyle changes, weight loss, eating healthy, etc. One of the important things to focus on is to let patients know the importance of staying active and still trying to exercise. Obviously, we still use physical therapy, etc., as well to assist with the pain of arthritis, non-pharmacologically. Obviously, as physicians, we have to always look at medications, the risks and benefits associated with their use. So what are the different non-pharmacological options there that are available? We often lose sight of these. We often tend to go more to the oral agents as a first line, often forgetting that there are some simple topical agents that are available both over the counter as well as in the form of prescriptions that can help patients. A very old one is actually capsaicin. It is one of the recommended guidelines to use, especially in the elderly for arthritic joints. Similar product now available is in the form of a topical non-steroidal anti-inflammatory called diclofenac. I find it very useful in my practice, especially for problematic knee joints, and especially in those patients who can't tolerate medications orally very well for a variety of reasons, particularly the elderly. Other oral agents, very traditional approach is, of course, the use of acetaminophen or paracetamol, as it is called in many countries, or Tylenol, as we call it over here. One of the key things to remember with this medication, although it's over the counter, there is a ceiling dose of 4,000 milligrams a day. One of the most interesting things I came to realize when I started working in this field is really the cautions one should have when dealing with oral non-steroidal anti-inflammatory medicines. The one thing to remember is that these medications are really indicated only for patients below the age of 75. We tend to use them quite often, even above the age of 75, on a case-by-case basis. But it is important that we're supposed to try to use the topical versions of this anti-inflammatory rather than the oral version, especially in the elderly. Why is that? Because we have several side effects associated with these medications. They are contraindicated in certain heart conditions. We have to be very careful in patients who are already on aspirin therapy. We now have a black box warning on several of these medications because of their correlation with heart attacks and strokes. Certain non-steroidal anti-inflammatory drugs do cause direct endothelial injury to the lining of our arteries. And so we have to be very careful of how we use them. This, of course, in addition to the issues with patients with gastrointestinal problems, liver problems, kidney problems, etc. We need to be mindful of these medications. Other kind of atypical medications that we use for the management of joint pain related to osteoarthritis, we don't often think of it commonly, but duloxetine is a medication that can help from a neurological type of perspective with relieving pain, especially where it comes from the knee joint. The other one, of course, is tramadol, which is a weak opioid medication. It is classified as a narcotic. We worry about its use because it can reduce the seizure threshold in certain patients. Interestingly, when you look at the randomized controlled trials of this weak opioid, it really had no more pain relief than an non-steroidal did, no more pain relief than ibuprofen could produce. It did seem to do better when it was studied versus Tylenol. Again, a medication that can be offered to certain patients on a case-by-case basis. What about the role of the strongest of our pain medications, or the narcotic or opioid analgesics? There's a lot of negative information, obviously, about them because of their misuse and their overuse. But, you know, in certain patients for whom nothing more can be done, they're not surgical candidates, or they need something temporarily as a bridge to, say, a joint replacement, it is reasonable on a case-by-case patient basis to offer this option to certain patients. Side effects, there's a plethora of side effects. We worry about constipation, dry mouth, dizziness, memory loss. Of course, we worry about falls in elderly patients. And most of all, we worry about the drug interactions due to polypharmacy. Most elderly patients are on several other medications, and so we have to be very careful with them. Another key point to remember is that these medications are not meant to be dosed in high doses. When you look at the trials, taking more than 50 morphine equivalents, or 50 milligrams of morphine equivalent, has really shown no benefit in studies. So start low, go slow, but it is an option for a few patients for whom nothing else can be done. Let's move on to our other current options that we have out there. We did some non-pharmacologic, we did some pharmacologic options. Let's look at the joint injection world. The most common injection we use today all over the world, really, for the treatment of major joint arthritis is cortisone, or steroid injections. We often get carried away with using these injections once every 3 months in patients, just to kind of maintain them until we can get them to a point where they're candidate for, say, a joint replacement. However, let's look at the research. Let's look at the trials. What did the randomized control trials really show about the use of cortisone injections? There is definitely a benefit when these injections are used, but it was considered mild and significant. And it only lasted for 3 to 4 weeks on average in patients. We forget sometimes the downside. It can elevate blood pressures. It can cause the sugars to be raised. In some patients, you can get symptoms like nausea and dizziness. I think one of the most concerning things with repetitive use of steroid is sometimes we lose track of the fact that there is good data that shows that there is a dose-dependent acceleration of cartilage damage. The very disease you're trying to treat or to help, you may in fact, with repetitive steroid injections, be causing an acceleration of that same disease. It's something to think about. Great choice, inexpensive, easily administered, but we need to remember those guidelines as well. Of course, as more research comes in, we are coming to find out that the repetitive use of cortisone injections, especially administered within 3 months prior to a joint replacement, can significantly increase that patient's risk of a periprosthetic joint infection. We see that quite conclusively in some recent hip arthroplasty trials, where there was an increased rate of these periprosthetic infections in those patients who had received cortisone injections too close to the date of their joint replacement. Still, something to consider, as I said before, in a patient who nothing more can be done, they cannot take oral agents, we have to use something as a bridge to joint replacement, etc. It can be a fairly good option. We often use them in the middle of flares of pain or large effusions, for example, in joints. How about rooster cones? Popular in use in sports medicine, orthopedic medicine, etc. But let's look at what the randomized controlled trials showed. The randomized controlled trials showed very differing and inconclusive outcomes, really, on effectiveness. So much so, in 2013, the American Academy of Orthopedic Surgeons actually recommended against the use of hyaluronic acid as a first-line therapy or even a second-line therapy for osteoarthritis. Later on, when the American College of Rheumatology looked at the same trials, even they came through with only conditional recommendations for this product. Those patients who have failed conservative treatment, topicals, oral agents, use this only as a bridge to joint replacement or in whom surgery is contraindicated. It can be very expensive. In the US, a series of rooster cone injections can cost patients anywhere from $600 to $1,200. It's not quite a cost-effective approach when you looked at the cost-benefit analysis. So what is the current thinking regarding regenerative medicine? There's been a lot of talk about this group of joint injections with varying types of therapies coming out over the last few years. There is hope for the future. I tried to categorize these regenerative injections into 3 specific groups to make it more understandable. The first group of injections is obviously your PRP, or your platelet-rich plasma therapy injections. The second group, which is more up and coming, is really the autologous conditioned serum, or the ACS injections. Those are the injections that we have done several of in our practice in the US. And of course, the third emerging group is the whole role of stem cells. Where do they feature in the world of assisting with joint pain? So what is PRP? PRP is basically the use of a patient's own blood where the platelet concentration is above the baseline. Platelet therapy basically is thought to contain growth factors that can stimulate some regeneration and perhaps some angiogenesis in the area, because they've been used in wound healing for some time now. The most important thing to remember, I feel, in this world of PRP is that a baseline platelet count of whole blood is on average about 200,000 platelets per micro ml. A therapeutic or a good quality PRP, therefore, should produce at least 5 times that baseline, which means a good device should produce a product that measures in at about 1 million platelets per micro ml. A good device is a high output device. When we look at different platelet-rich therapy devices we use, we may not see those numbers all the time. Does it work? Let's look at the data. A meta-analysis done showed, after looking at 905 articles over 13 randomized controlled trials in sports medicine, that the benefits of PRP therapy are really inconclusive. Why is that? Again, it goes back to the fact that there are a variety of different devices, some low output, some barely producing a platelet count higher than a baseline count of whole blood. Some produce levels of 800,000, and only a few produce levels close to 1 million platelets per micro ml. When you look at all those trials, the meta-analysis clearly showed that there have been only about 5 randomized controlled trials where PRP actually showed benefit, that too in mild osteoarthritis only. Those trials seem to be specific to the high output devices with a good platelet count level, and most patients had to receive at least 2 doses for the product to be effective. Let's move on to autologous conditioned serum, or the second group of joint regenerative medicine injections. Autologous conditioned serum is basically the use of a patient's blood with a platelet concentration above the baseline, just like PRP, but in addition, it has a high level of an anti-inflammatory protein called interleukin-1 receptor antagonist protein. There are various abbreviations for this name. We refer to it as IRAP, IRAP, or IL-1RA. IL-1RA or IRAP is actually a naturally occurring anti-inflammatory protein. If you go back to what I said about what causes or what triggers off the beginnings of inflammation in a joint, I would direct you to this next little slide, which clearly centers in or focuses on the role of IL-1 beta. It's the little text you see right in the middle of that slide. That is your master conductor of your inflammation cascade. When a joint receives a trigger, either because of repetitive friction, too much mileage, repetitive stress, a traumatic injury, a fall, a sprain, anything, it causes a rise in the levels of this master conductor of this organ off. Immediately we get a downstream of other pro-inflammatory chemicals, which then proceed to destroy the joint, lead to all the symptoms of inflammation, which are pain, swelling, warmth, stiffness, restricted range of motion, etc. And ultimately, treatment is required. So the reason for that slide is because it clearly explains the role of ACS, which is, in the next slide, you can see over here, the cell membrane where you have the IL-1 receptors clearly laid out. If IL-1 gets triggered off by binding in that receptor, you have your inflammation cascade. However, what ACS does is it produces the IL-1RA, which go in and occupy that receptor. So they block the IL-1 receptor, thereby IL-1 cannot bind further and then start its inflammatory action. Arthritis is therefore caused by an imbalance between pro-inflammation chemicals and anti-inflammatory chemicals. In order to block the effect of IL-1 or IL-beta, or the main trigger that starts the cascade of inflammation, a high dose of IL-1RA is required. Research has clearly shown that in order to receive or to achieve any therapeutic effectiveness, a block of at least 10:1, IL-1RA is to IL-1 beta, is needed to produce any kind of anti-inflammatory effect, thereby reducing inflammation, etc. in the patient. There are 3 devices out there that can actually produce autologous conditioned serum, which contains a high dose or high level of IL-1RA or IRAP. The first device is commonly referred to as the orthokine device, which was originally developed in Germany. The famous basketball player Kobe Bryant was one of the first recipients of that injection. And since then, many famous athletes, even a pope, etc., have received considerable benefit from a series of those injections. In the US, we have another product called Arthrex, which is only approved in the veterinary field. Third one is actually a process that has been adopted called the arthrokinex process, where we use a generic PRP device, but it is used off-label in a patented process to produce a high level of IL-1RA. The results of the analysis done with ELISA assays is actually laid out for you below. You can see at baseline the IL-1RA prior to this patented process was about 549 picograms per ml. However, post-processing, post-conditioning processing, which takes about an hour on-site in the clinic, levels of IL-1RA or IRAP in that serum was as high as 17,500 odd picograms per ml. What was very interesting and very innovative was to also look at the results of the other ELISA testing, which showed that the pro-inflammation cytokines like IL-1 beta, IL-10, TNF alpha were not statistically increased by the process at all. The therapeutic block produced by the process, if you remember, I suggested to you that you needed a block of 10:1. Well, this process produces a block of over 950:1. How do you compare the two? I like to refer to ACS, or autologous conditioned serum, as PRP+. Why? PRP contains only growth factors, but ACS contains growth factors plus huge levels of anti-inflammatory IL-1RA in it as well. The other thing that comes out at you straight away is that we have a variety of PRP devices, a variety of processes, etc. No real straightforward clinical protocols. Whereas here on the ACS side, we have some standard devices, standard processing, standard clinically reproducible protocols. Excellent randomized controlled trials on the efficacy of ACS, particularly out of Germany. I'll summarize them for you on the next page. Whereas, again, as I said, PRP, very scattered science on the efficacy of it. One of the most important things that I took from looking at the original research on ACS is that the patient populations were really patients who were patients like mine, not just patients with mild and moderate arthritis, but many of the patients that were in the trials had moderate arthritis, severe arthritis, and really bone-on-bone arthritis. And there was still some clinical effectiveness in that group. Contrast that with the few randomized controlled trials on PRP, where the effect was only seen in patients with mild to moderate arthritis. Of course, the final point to make really is that when it comes to ACS, with one blood draw, we have the ability to prepare 6 to 12 injections for that patient, which can be stored in a biofreezer and then administered every 3 months or so to that patient. On the other hand, when you look at PRP, usually most kits produce the volume of serum only for one shot, which therefore requires the patient to undergo another shot and additional cost. ACS treatment, in case y'all haven't read about it, is actually available in most of the EU. It's available in Australia. It's been approved in Germany, and it's been used in a variety of situations, even outside of treating osteoarthritis. My best estimate was that there have probably been over 400,000 ACS injections worldwide now at this time. I have a list of the various trials. If you'll contact me offline, if you can always get the further details of these studies from me. But essentially, we have some excellent trials on the value of ACS, improving pain and function in knee arthritis, spine arthritis, using ACS instead of cortisone in epidural injections, hip arthritis. One of the most interesting applications is looking at ACS use in the field of sports medicine, particularly injuries like ACL tears. This was a study done at Duke in the US, where they injected athletes with ACS prior to their ACL ACL repair, only to find out that those athletes had less perioperative pain, less requirement for pain medication, etc. Soon after their surgery, they were able to start physical therapy quickly. And most importantly, for an athlete, they were able to return to their sport quite soon as well, which was important. There is now some extra information as an addendum that's come out in those studies, that it even reduced the kind of the long-term complications of tunneling, etc., post-ACL in certain athletes. They're using ACS even in the treatment of muscle sprains in athletes to try to return them to their sport sooner than the norm. What about stem cell injections? The whole idea of using stem cell injections is to take a sample of undifferentiated adult mesenchymal stem cells, mainly derived from either the adipose tissue or bone marrow, and re-inject it into the joint. The idea is to improve or support the self-healing process going on in the joint. There's some good information that adding stem cell into a joint can help with mitosis, angiogenesis, etc. Does it work? We've started to get some good results. Studies, we have about 3 or more, I think, randomized controlled trials, suggesting that stem cell injections may improve pain and function. However, again, no optimal protocols are out yet. There's no optimal dose. The biggest concerns we see are related to age, smoking. What about the quality of stem cells from diabetics, from COPD patients, from patients who struggle with other metabolic illnesses, for example, or even other blood-based illnesses? There are some strict criteria that should be implemented when considering patients for stem cell injections, mainly maintaining a BMI below 36. The joint has to have at least as well. What is the FDA's stance, or what is the worldwide stance on using blood products or regenerative medicine injections in athletes specifically? In 2011, the World Anti-Doping Agency and the US Anti-Doping Agency basically allowed athletes unrestricted use of same-day therapy. Basically, as long as the regenerative medicine, joint injection, or area injection therapy is performed the same day as the draw with minimal manipulation and homologous preparation, there was no problem with this area. There are some new drugs under development, interestingly, just to look at. One of the major groups they're looking at is IL-1 inhibitors. Again, the same target or the same therapeutic target that the ACS injections goes after. Block that IL-1 and you'll probably reduce inflammation in that area. The other group are the ADAMS5 inhibitors. And of course, we're starting to look at now the use of other biologicals from other types of arthritis, such as rheumatoid arthritis, psoriatic arthritis, etc. We're looking at some studies of how these may work in patients with osteoarthritis as well. That's all I have for you today. Again, I work in Oklahoma City. I direct the Arthrokinetics Joint Health Program here. And to date, we've done about 1,500 injections with some good results. We continue to collect our data and partnering with an IRB, Integra Review, we intend to continue to publish as we go forward. Thank you very much for your time.